এখানে চলছে আমার ফোনটা যে কি করেছে এটা ভালো আরে সামনে ইয়েগুলো আছে আরে লক স্ক্রিনে ভিডিও আছে না হ্যাঁ এবং চেঞ্জ আছে সেটা কালকে রাত থেকে হচ্ছে আমাকে দেখ ভালোবাসে আমি তোর জন্য ওইখানে জায়গা রাখতাম ও নিয়ে নিয়েছি
দেখতে পাই না আমার চোখের জন্য
তুই তাহলে স্যারের পাশেও যেতে পারিস স্যারের পাশে দাঁড়িয়ে দাঁড়িয়েও ক্লাস করতে পারিস
পারলে
নাম্বারের কি আছে নাম বানতে হয় ডিসপ্লে দিছে একটা দিয়ে দিচ্ছি আমি ঠিক আছে
Let us see a little things about the liver. So what is the blood supply of the liver basically? What is the blood supply of the liver? Hepatic artery and hepatic artery and hepatic artery and what is the blood supply of the liver? What is the blood supply of the liver? Hepatic artery and portal vein, which supplies the majority of the blood supply. Portal vein. Clear out? 70%. So mainly portal vein carries nutrients, right? So whenever you take the food, or automatically the pathogens, if it is contaminated, the pathogens will be entering into the food. Is it or not? Along with the food, it will be entering into the GIT. Okay. So there is a term called amoebic liver abscess. Okay. Amoebic liver abscess is caused by Entamoeba histolytica. The pathogen here is nothing but the Entamoeba histolytica. For example, it has entered into the gastrointestinal tract. Okay. So that pathogen through the portal vein will be entering into the liver. Is it or not? Because portal will be carrying nutrients. So obviously through the portal vein, the pathogen, nothing but the Entamoeba histolytica, also will be entering into the liver. So okay. So whenever a pathogen enters into the liver, so obviously there will be a fight between the antibodies and the antigens. Is it not? So that results in the formation of pus over here. So the liver is covered by the Glissen's capsule. If the pus is within the substance of the liver, so it will be sealed in between the Glissen's capsule and the substance of the liver, forming a cavity. Is it not? So the cavity filled with the pus is called the abscess over here. Okay. For example, if the abscess has formed at the level of bare area of the liver, the bare area of the liver. Okay. So the bare area of the liver, towards the bare area of the liver, if the abscess has formed over here. So where it will enter, where the other areas, this abscess, the infection can spread. Through? What? It's okay. Greater side, it's okay. See, for example, there is an abscess at the level of the bare area of the liver. The bare area of the liver is connected to the diaphragm by means of superior and inferior coronary ligaments. Okay. So this will be in contact with the diaphragm. Is it not right? So through the diaphragm, this infection will be spreading through the lymphatics towards the thoracic cavity. Is it not right? Through the diaphragm, the lymphatics of the abdominal cavity will be communicated with the thoracic cavity's lymphatics over here. Okay. So the lymphatics of the thoracic region communicates with the thoracic lymphatics over here through the diaphragm. So where this infection can spread to in the thoracic cavity? Above the diaphragm, above the liver, which structures are present? Heart and lungs. This is not towards the right lobe of the liver. There will be a relationship of
Right lung.
right lung. Towards the left lobe of the liver, there will be
Left lung.
it will be in the middle of the liver. Okay, towards the left lobe, there will be the left lung. So we are focusing on the bare area of the liver over here. Okay, so it will be spreading to the right lung over here. Is it not? If the infection is spread towards the pleural cavity, what will happen over there? Pleural effusion in the form of empyema. Empyema means pus collection within the pleural cavity. Is it not right? So that will be leading to pleuritis. Okay. The patient will be having the pain and difficulty in breathing towards the right side of the chest. Is it not? So the abnormality is over here that has spread to the liver and then further spread to the lungs over here. This is the continuity over here. Getting it out? Right? Okay. So there is another clinical anatomy over here. It is nothing but the cirrhosis of the liver. Cirrhosis of the liver occurs in exactly. Cirrhosis of the liver because of the chronic alcoholism, not acute alcoholism. Acute means less amount of duration, like less than 3 months or something like that. Chronic means more than 3 months. Okay. So that alcoholism again will be entering through the small intestine and the toxic substances will be absorbed through the portal vein and will be delivered into the liver over here. Get it down? So if the toxins are entering into the liver, what will happen? So inflammation will occur as a response. Is it not? Inflammation will occur as a response. If there is an inflammation within the liver, so one of the things which occurs is nothing but the fibrosis of the liver. Is it not? Fibrosis is a part of inflammation of the fibrosis is a part of inflammation. Okay. So in case of liver cirrhosis, the substance of the liver will undergo fibrosis over here. Okay. So this fibrosis ultimately forming the nodules within the liver. Nodules means raised structures over here. Okay. So these raised structures and this fibrosis is leading to the scarring of the liver. Just like the wound scar how we get, the scarring will be occurring in the liver over here. Getting it out? So what will happen if the liver undergoes fibrosis and scars occurs within the liver? What will happen? For example, portal vein is going over here. Exactly. Portal vein, the blood will be passing all the way from the intestines towards the liver. But because of this scarring, there will be obstruction of the portal vein within the liver over here. Is it not? Right? So what will happen? Normally the portal vein's blood pressure will be around 80 to 100 millimeters of mercury. Okay. So that pressure will be backed up. Is it not? The pressure, with some pressure, it is going into the liver over here. but there is an obstruction to that pressure. So that pressure will be backed up through the portal vein back over here. Getting it over? So what will happen if the pressure is reversed over here? So the pressure within the portal vein is increased over here. So indirectly there will be the hydrostatic pressure increase also. Is it not? The blood contains water or not? So the hydrostatic pressure within the blood also will be increased over here. Right? So the portal vein will be having semi-permeable membrane. Is it not? All the blood vessels will be having semi-permeable membrane. So the water will be leaked into the peritoneal cavity or abdominal cavity because of this portal hypotension. Could you understand all right? Right? The vein, there is an obstruction, the pressure within the vein will be increased over here. So because of the increased pressure, the water content within the blood will be leaked into the peritoneal cavity or abdominal cavity. So the peritoneal cavity will be filled with the fluid over here. Getting it over? So that is termed as ascites. Okay, ascites over here. Getting it over? So this is one effect of the portal vein obstruction over here. Another effect will be which veins? Okay. But we will see in the esophagus. Okay, esophagus. Okay. So there will be the gastric veins which are draining the esophagus. Abdominal part of the esophagus will be drained by the gastric veins. We know that the left gastric artery will be giving rise to esophageal branches. Is it not? The same manner, the esophageal veins will be draining into either left gastric vein or directly into the portal vein over here. Getting it out? So because of this obstruction, there will be backed up pressure into the esophageal mucosa over here. Getting it out? So because of this backed up pressure, there will be dilated veins within the mucosa of the esophagus into the esophageal lumen. Getting it out? So this mucosa will be burst open and the blood will be trickled downwards into the stomach over here. Getting it out? So because the blood acts as an irritant within the stomach, that will be vomited out. Getting it over? So that is termed as hematemesis. Emesis means vomiting. Hemat means blood vomiting over. Getting it over? So esophageal varices will be found. Varice means, already I have told you what is varice means. Varices, varicocele or distension of the vessels is called varices over here. Okay. So because of this backed up pressure within the portal vein, the gastric veins over here, so the esophageal veins over here will be undergoing distended within the mucosa of the esophagus towards the lumen. So the blood will be released or leaked into the stomach over here, and that will be vomited out in the manner of hematemesis over here. Got it out? So these are the effects of the portal hypotension. Getting it out? Right? So the patient of some age, whatever it might be, 40 years or 30 years of age, complains of pain in the right upper abdomen, okay, and having fever with chills. Okay, fever with chills means? Chills means? Shivering sort of, okay, feeling cold, lot of cold. Okay. So complaints of course, generalized body pains, and the pain is not only present over in the right hypochondrium, but is also felt over the right iliac fossa. What might be the reason? The patient came with the complaints of pain in the right hypochondrial region initially, but later on he is feeling the pain in the right iliac fossa, again having the symptoms of fever, chills and everything. So what might be the reason of it? What right? What about it? Gallstone. So what might be the reason, right? What might be the reason? What is? No. So what I said, the pain in the right hypochondrium, having the patient is having fever and chills. Fever and chills is constant. Okay. Initially the patient complained of pain in the right hypochondrium, but later on he complained pain in the right iliac fossa. So what is the relation between these two? paracolic gutter. So if the abscess burst open in which region? At the level of right hypochondria. What is it? Hepatorenal pouch of Morrison. What is that, right? Which pouch? Which pouch? Which pouch? Which pouch? No. Which pouch, right? Where is that? Right side of the liver. How it is formed? Hepatorenal pouch. How it is formed? Okay. How the hepatorenal pouch communicates with the right iliac fossa? How hepatorenal pouch communicates with the right iliac fossa? Right? Anybody? To the right paracolic gutter. To the right paracolic gutter, the right hypochondriac region of hepatorenal pouch will be communicating with right iliac fossa. Okay. So is there any chance that it may extend into the lesser sac or not? From the right, from the hepatorenal pouch of Morrison, how it can communicate? Side by side. Epiploid foramen. Can the infection enters into the greater sac? How? To and fro. Or anteroposterior direction or posterior direction. Right? Hepatorenal pouch will be communicating with the greater sac on the anterior aspect, or lesser sac will be communicating with the greater sac on the anterior aspect of the stomach. Right? So two-way communication, side by side and to and fro, or anteroposterior, posterior, anterior direction. Got it or not, everybody? Right? So today we'll see the stomach. So what is stomach?
Picture of the human body.
It's not the human stomach. Where the stomach is situated, in which regions of the abdomen? Epigastric, hypochondriac, and umbilical regions. What is it? Epigastric, left hypochondriac, and umbilical regions. Because you know that already the liver left lobe will be coming over here, and the inferior surface of the liver is related to the stomach. Which area? Greater curvature or lesser curvature? Lesser curvature. What's the lesser curvature? Okay.
When we eat food or when we generally
What is the word?
when we eat food or when we generally draw why don't we the left
What you are asking that?
Left lumbar.
To some extent, but mainly it will be in the left hypochondriac, epigastric, and umbilical region. To some extent, because of the distension of the stomach, it may extend to the left lumbar region. May extend. Okay. So this is the fundus of the stomach. Fundus of the stomach, the summit will be reaching till fundus of the stomach will be reaching till fifth intercostal space. Okay, which will be very much close to the apex beat of the heart. Where is the apex beat of the heart? Yeah. So apex of the heart will be situated around 9 centimeters maybe from the midline within the fifth intercostal space. Is it alright? So this fundus will be reaching to that point. So this fundus of the stomach will be reaching the apex of the heart. Okay. For example, if the stomach is filled with excessive gas over here, so that will lead to distress of the heart over here. Getting it alright? So that will be pushing over the heart. So the patient will feel distress in the thorax because of the compression of the heart over here. Getting it alright? Right? Okay. So this is the topographic things of the stomach over here. What are the parts of the stomach? Parts of the stomach?
cardiac fundus, body
end of the stomach. So let us see that this is the abdominal part of the esophagus, just below the diaphragm over here. And this is the cardiac end of the stomach, towards the heart over here, cardiac end of the stomach over here. From this part will be reaching the fundus. So whenever you draw a line horizontally all the way from the cardiac end, horizontally over the stomach, that will be giving rise to fundus of the stomach. Fundus, body and pylorus over here. Fundus, body and pylorus are the three parts of the stomach. Getting it? Fundus is lying just above the horizontal line drawn all the way from the cardiac end of the stomach over here. Wherever the esophagus ends, wherever the stomach starts over here, that is the cardiac end of the stomach over here. Okay. So then followed by, this is the lesser curvature and this is the greater curvature of the stomach. You already know very well, right? So this lesser curvature will be having a vertical limb over here and turns into the horizontal limb over here. At this area, there is an angle over here. That is called incisura angularis. Okay. If you draw a line, okay, sorry, we'll see that. So this is the incisura angularis over here, and then followed by this is the greater curvature. This greater curvature will be having two notches whenever it reaches the lower part over here. One notch towards the left side, one notch towards the right side over here. Okay. So this dilated portion between the two notches is called pyloric antrum. So, if you join an oblique line over here, all the way from incisura angularis towards the notch over here, so that will be dividing the pyloric part of the stomach from the body over here. So far we have formed the fundus of the stomach and now body of the stomach over here. Okay, body of the stomach will be in between this horizontal line and then followed by this oblique line all the way joining the incisura angularis and the notch between the body and the antrum, dilated portion of the stomach, pyloric part of the stomach over here. So if you join these two angles, that forms the body over here. From then onwards, the rest of the part is nothing but pyloric part of the stomach. Pyloric part of the stomach contains again three parts. What are those? This dilated portion is called the pyloric antrum, and then further followed by pyloric canal, and then finally pyloric sphincter, to be frank. Pyloric sphincter. Why this pyloric sphincter is needed over here? What? Yeah. To control the gastric emptying. Why there is a control? There must be control over here. Gastric emptying.
Also prevent the backflow.
Backflow will be prevented all the way from duodenum towards the stomach. And what else? What? So okay, what is the normal mechanism of the digestion? Why the sphincter will be closed? So whenever your stomach is empty, the sphincter is closed or open? Open. So whenever your stomach is empty, what will happen? The stomach, the sphincter and the rest of the musculature of the stomach, what will happen? What will happen? Sphincter must be closed and this must be relaxed over here. Then only whenever you take the food will be collected as a reservoir over here. Getting it out? And then that food, wherever entered, will not be immediately entering into the duodenum. That's why the sphincter must be closed over here. Getting it out? You don't know when you are going to take the food. At that time, the sphincter will be closed over here. Okay. For example, if it is remaining open, what will happen? If the sphincter is, in case of empty stomach also, if it is remaining open, what will happen? Absolutely. The acid clearly will be entering into the duodenum, leading to the peptic ulcer over here. So the sphincter must be closed over here. But you will understand or not, right? So in case of empty stomach, it will be relaxed and this will be contracted over here. Sphincter will be contracted over here. And one more thing to identify the pyloric sphincter, there is a vein over here. Exactly. What is it? Prepyloric vein of Mayo. Okay. So there is a vein called which drains the pyloric part of the stomach that will be drained into right gastric or into the portal vein directly. Either portal vein or right gastric vein over here. Okay. So this vein is nothing but the pre-pyloric vein of Mayo, is an indication or it is a hallmark for the identification of the pyloric sphincter over here. Based on this, the surgeons will be operating over here. Getting it out? Right? So whenever they found a vein over here draining it into the portal vein or the right gastric vein, which is draining the pyloric part of the stomach, which is called the pre-pyloric vein of Mayo. So then the surgeons can perform the surgeries over here based on this vein presence over here. Getting it out? So this pre-pyloric vein of Mayo is the hallmark for the identification of the pyloric sphincter or pyloric orifice opening over here. Getting it out? Right. So these are the parts of the stomach. Sorry, 3 parts of the stomach. And what are the surfaces and borders of the stomach? Antero superior surface and posterior inferior surface. These are not anterior surface and posterior surface. Antero superior surface and posterior inferior surface. And what are the borders of the stomach? Exactly. Lesser curvature will form the right border of the stomach and greater curvature will form the left border of the stomach because this curvature is facing the left side and this curvature will be facing the right side over here. Getting it down? So 2 borders on either sides and surfaces are there over here. And what are the ends? One is the cardiac end and one is the pyloric end over here. So, what are we discussing? Borders and ends to cardiac end and pyloric. Okay. So, what are the relations of anterior-superior surface of the stomach? Where it is situated actually? That is, what are the relations of the anterior-superior surface of the stomach? So, if it is in the left hypochondriac region, what structures will be coming in contact with the anterior-superior surface over here?
We have coastal cartilages.
What? Coastal cartilages, is it not?
Right lobe of left lobe of liver.
Yeah, okay, it's okay. So coastal cartilages and left lobe of the liver. We have seen this part of the stomach is covered by the inferior surface of the liver. Is it not? So anterosuperior surface, the fundus part and the body part and the pyloric part will be in close contact with the inferior surface of the liver. Is it not? Towards this side, hypochondriac region, it will be covered by coastal cartilages. Is it not? Coastal cartilages, right? Okay, diaphragm and coastal cartilages. Okay, fine. So this part will be empty over here. Is it not? So below the stomach there will be transverse cord. Is it not? So if you consider this part is covered by the liver over here, and this part is covered by the coastal cartilages over here. This is the free part, which is the triangular area of the stomach over here, which is straight away in contact with the anterior abdominal wall. So why this triangular area is needed normally? Why we are supposed to know?
Sir,
It's not
for
collapsing.
esophageal obstruction, we can directly pass food.
Yeah, absolutely. So, exactly. What is it? Gastrostomy. Okay. So we can understand here is the costal cartilages. These are the costal cartilages over here. And this part is the liver. This part is the liver in this manner. This part is the liver. Okay. And these are the costal cartilages which are covering the stomach on the anterosuperior surface. And this part is the triangular area of the stomach which is in close contact with the anterior abdominal wall. So if there is any obstruction in the esophagus because of the malignancy or whatever it might be, so the food can't be entering into the stomach over here. So at that time, you have to make an opening in this region, nothing but the triangular area of the stomach over here, through which you can insert a tube into the stomach. Okay, what is the tube like? Okay. So this opening and putting the tube into the stomach to feed the patient. That means the food will be carried through this tube into the stomach directly, apart from the esophagus over here. Okay. So this making an opening over here is nothing but ostomy means open, just open. Ectomy means gastrectomy means it is removal of the stomach. Ostomy means opening. Putting an opening in the stomach is called the ostomy over here. So if you are putting an opening at this triangular area over here and putting a tube into the stomach to feed the patient by passing the food materials through this tube into the stomach directly, bypassing the esophagus over here. So that's why we are supposed to know about this triangular area of the stomach over here. Getting it out, right? So this triangular area, what are the boundaries? Towards the left side is the costal margin, left costal margin, all the way from 7th costal cartilage, 8th, 9th and 10th costal cartilage. Everything will form the left costal cartilage, left costal margin. And then this is the inferior border of the liver because it is covering this part of the stomach over here. And then below by means of this transverse colon over here. So this is the triangular area which is formed over the anterosuperior surface, and these are the boundaries over here. And this is the use for knowing this triangular area of the stomach over here. Understood or not, everybody? Right? Right. There is an area called drop space. Somebody?
In the fundus.
Drop space.
In the fundus, we can do tympanic.
Okay.
Percussion. This tympanic on percussion is very good. But in case of hepatomegaly or some
exactly.
it is distant. The sound is different.
Absolutely. Straight away. So how are all the other stars? So what are the boundaries of this drop space over here? So there is a space called the drop space which will be a short note. Okay, you're supposed to understand what are the boundaries of this drop space and why it is needed over here. Okay, first of all, the drop space is a topographic region. What does topography means? What does the topography means? So over the body, what does the topography means? Location. So you are not directly opening the abdomen and you will be looking over this drop space in the abdominal cavity over here. You are locating through the skin wherever this drop space is present, just like the surface marking over here. Okay. So this drop space you are supposed to know topographically, not by opening into the abdomen. Getting it all right? So where it is situated? Very easy. The inferior border of the liver or towards the right side and left side by means of spleen over here. Is it alright? Stomach is present over here. Obviously there is a spleen over here. Okay. Lateral end of the spleen. Okay. Medial end will be close to the stomach over here posteriorly, and lateral will be a bit away from the stomach over here. Okay. And then above by means of the lower border of the left lung over here. Okay. Towards the right side there is an inferior border of the liver. Towards the left side there is a lateral end of the spleen. Spleen will be in this manner. Spleen will be in this manner. It is having medial end towards the midline and lateral end away from the midline over here. Okay. So stomach will be lying exactly over here in this manner. Getting it all? Right. So this is the lateral end of the spleen towards the left side. Above by means of lower border of the left lung. Could you able to see that? This is the lung, these are the ribs over here, and this is the lung over here. Could you able to imagine or not? Right? Could you able to imagine or not? Right? Right. So this is the left lung, inferior border, and inferior border of the liver over here, and lateral end of the spleen. Exactly in between these three will be the drop space. Okay, this space is a drop space over here. This area is a drop space. So why this drop space is supposed to be understood over here? This, whenever you focus over here, it will be giving rise to resonance, right? Resonance, right? So whenever there is a splenomegaly, for example, or for example, whenever there is a hepatomegaly over here, or whenever there is a pleural effusion over here, this drop space will be overlapped by all these megalies over here. Okay. For example, when the spleen is enlarged over here, the spleen will be going obliquely downwards in this manner. The enlargement will be going obliquely downwards in this manner. So whenever the spleen is getting enlarged, do you think the spleen will be enlarged in case of portal hypertension or not? Why? In case of portal hypertension, the spleen is getting enlarged. Why? What? Exactly. How the portal vein is formed? Whenever the splenic vein joins with superior mesenteric vein. Splenic vein joining with superior mesenteric vein, it will be forming the portal vein. Whenever there is a portal hypertension, the pressure not only will be delivering into the formation of ascites over here, the pressure will also be going back through the spleen, splenic vein into the spleen. Is it not? The pressure will be carried back towards the spleen also, apart from the esophagus over here. So what will happen whenever the pressure is backed up over here? So the blood will be pooled more in the spleen. Is it not? Spleen is a temporary reservoir of the blood. But whenever there is an obstruction over here, so more blood will be accumulated within the spleen. So to accumulate more blood, the spleen will get enlarged over here. So the splenomegaly occurs in case of portal hypertension. So totally 3 entities we have seen so far. Portal hypertension will be leading to ascites formation, and one is esophageal varices, which is leading to the bleeding within the stomach and esophagus also, and then followed by splenomegaly. So if the splenomegaly occurs over here, this area of the stomach will be overlapped by this enlarged spleen. Getting it out? Or if the hepatomegaly occurs over here. Okay. So the hepatomegaly also overlaps this drop space over here. Or if the pleura, which is present over here, pleura will be extending till 8th postal cartilage or 8th intercostal space over here. Okay. So if the pleural effusion occurs, so this will be overlapped by the pleural cavity over here. So again, this drop space will be obliterated. So 3 conditions: one is the hepatomegaly, one is the splenomegaly, one is the pleural effusion. So everything will be occluding this drop space, so you can approach a particular probable diagnosis over here, whether by splenomegaly or hepatomegaly or pleural effusion, based on the signs and symptoms of the patient. Getting it or not? So if the drop space normally will be having tympanic note, nothing but the resonance over here. So if the resonance is lost, which is replaced by dullness, either it may be because of hepatomegaly hepatomegaly, or because of splenomegaly, or because of pleural effusion. You can approach your diagnosis over here. Getting it or not? So if the patient is complaining of respiratory distress, so you can relate this part with the lungs over here. In case of malaria, there will be. In case of malaria, there will be splenomegaly, right? In case of malaria, there will be splenomegaly. So that will be obstructing the strom space over here. Okay, and liver pathology, hepatomegaly over here. So this is the usage of the knowing of strom space over here and triangular area of the stomach over here. Getting it already, everybody, right? So far we have covered the anterosuperior surface and posterior inferior surface will be forming, not posterior inferior surface will be resting on a bed called stomach bed. So this stomach bed is formed by what are the structures which are forming the stomach bed on which the postero-inferior surface lies over here? What are the structures? Left crest of the diaphragm. So you have to imagine the stomach will be lying in front of the pancreas and kidneys. Is it not? Stomach will be lying in front of the pancreas and kidneys over here. You know the picture, right? So the stomach, which is mostly situated towards the left side over here. So all these structures which are lying behind the stomach will be forming a stomach bed, which will be forming a concave area over here, all the way from this part till the transverse mesocolon. Is it alright? In the transverse mesocolon, if you see that kidneys are the retroperitoneal structures, obviously, and then followed by the anterior border of this pancreas over here. In front of that, here will be the transverse mesocolon. So it is like a concavity which is forming the bed of the stomach over here. Getting it out? Right? So what are the structures which are forming the bed over here? First of all the way from medial to lateral. Left crest of the diaphragm over here. Left crest of the diaphragm will be extending till which vertebra? L2 vertebra. Right? Right will be L3 vertebra. Why so? Right lobe. So right crest will be pulling the liver downwards during inspiration. Is it not? During inspiration, the liver will be pulled downwards by means of diaphragm with more energy. So that's why there will be thickened and a longer right crest of the diaphragm. Okay, left side is not that much needed. So it is extending till the L2 vertebra. Right? Okay. First of all, left crest of the diaphragm. By the side of it will be left suprarenal gland and upper half of the anterior surface of the kidney. Which kidney? Left kidney. So pancreas, towards this pancreas will be the right kidney over here. Towards the tail part will be the left kidney over here. Okay. Anterior surface of the left kidney, the upper part. Why not the lower part over here? Why not the lower part of the anterior surface of the kidney over here? Very much logical. Retroperitoneal, absolutely, because the transverse mesocolon will be attached over here in this manner, right? And the stomach will be lying over here. So the lower portion of the kidney will not be coming in contact with the posterior inferior surface of the stomach. Getting it out? So it will be like a sheet which is present over here. Getting it out, right? Right. And then followed by the splenic artery over here. And then followed by this part. What is this part? What is this surface of the pancreas over here? Anterior surface and inferior surface of the pancreas over here. If you take the pancreas body, it will be triangular in this manner. Okay, this is the anterior border, this part is the anterior border, here is the anterior surface, here is the inferior surface, and behind this is the base or posterior surface over here. Getting it up? So this anterior surface, towards this anterior border will be the transverse mesocolon going in this manner. So only the anterior surface will be coming in contact with the stomach, posterior-inferior surface of the stomach, not the inferior surface of the pancreas over here. Because it is overlapped by the transverse mesocolon in this manner. Getting it down? You know how the transverse mesocolon will be diverged at the level of the anterior border of the pancreas or not? You know or not? Transverse mesocolon, how it will diverge? Two layers will be present. How they will diverge? Towards the posterior abdominal wall. How right? How? Yeah, you do. The middle one. The next one. How the transverse mesocolon will be attached to the pancreas. The two layers, how they will diverge. Okay, third and fourth legs, it's okay. How they will diverge? For example, if this is the transverse colon over here in a sagittal section, and this is the pancreas over here, transverse mesocolon will be enclosing the transverse mesocolon over here, and this is the upper layer, and this is the lower layer, and this is the posterior abdominal wall over here, sagittal section. This is the transverse colon over here. This is the upper layer of the transverse colon. This is the lower layer over the peritoneum over here. This is the upper layer. This is the lower layer. Whenever they both join towards back of this transverse colon, the two layers will be again joined over here, forming the transverse mesocolon. That upper layer will be diverged above the pancreas and joins with the posterior abdominal wall over here, and the lower layer will be diverged again at the level of the anterior border of the pancreas over here. And that will be again continuous with the lower part of the abdominal peritoneum over here. Understood or not? Could you able to remember or not this one? Okay. Okay. So that is why the stomach will be resting at this point. The stomach will be resting in this point over here. The posterior inferior surface of the stomach will be resting in this concavity over here. So the lower surface, nothing but the inferior surface of the pancreas will not come in contact with the posterior inferior surface over here. And the kidney which is lying over here, the lower part will not be coming in contact with the posterior inferior surface of the stomach over here. Could you understand? So because the stomach is diverted over here, so the pancreas, the lower portion, and the kidney, the lower portion will not come in contact with the posterior inferior surface. Understood or not? Right? Okay. And then the other beds are nothing but the spleen. Okay, gastric impression over the spleen. You'll be learning it later. Okay, first of all the way from medial to lateral direction. The left crest of the diaphragm, and then followed by suprarenal gland, and followed by kidney, and then followed by splenic artery, and then the surface of the pancreas, anterior surface of the pancreas, and then followed by spleen. All these things will be forming the stomach bed. How the stomach will be lying? It will be lying over here in this manner. Getting it out? Right? So everything on the posterior inferior surface will be related to all these structures over here. Behind this will be all these structures, which is forming the stomach bed. Got it or not, everybody? Understood or not? Right?
So whatever the splenic flexion is there,
Splenic flexion? Yeah, it may sometimes come in contact with that. Okay. So sometimes the left colic flexion comes in contact with the stomach bed over here. Sometimes, not all the time. But these are the basic things which are forming the stomach bed. Aorta. Obviously it will be coming. Aorta will be staying over here. Aorta will be staying over here. So towards the midline over here. Indirectly it will come in contact. But these are direct contacts over here. Getting it? So for example, behind this is the posterior abdominal wall. It will not be coming in contact over here. Only the kidney will be replaced over here. Getting it? So whatever the structures which are in close contact with the stomach wall over here, those are the bed structures over here. Not which are indirectly related over here. Getting it? Right? So let's supply and venous drainage of the stomach. So what are the vessels which supply the stomach? What are the vessels which supply the stomach over here? So what are the branches of the, what is this artery? Towards the lesser curvature of the stomach, there are two arteries anastomoses within the lesser omentum of the stomach. Is it not? What is the omentum means? What is the omentum means? What? Fold of peritoneum? It's okay. We can call it as mesocolon also now. Why it is omentum? Why it is termed as omentum? Yeah, okay. What is made? Okay, liver and lesser curvature system, that's okay. Why it is called an omentum? There is a great omentum also. No? Why it is omentum? Anybody omentum? Why it is omentum? Connects the stomach. Fold connects the stomach with other organs is called the omentum. Got it? Right. So here will be the lesser omentum all the way from the liver. So the lesser omentum contains vertical and horizontal parts. Is it not? The vertical part is attached towards the liver too. Which part of the liver? There is a lesser omentum in this manner. This is the vertical part and behind this is the horizontal part. Vertical part is attached to? Vertical part is attached to? Groove for? This is the vertical part and this is the horizontal part, nothing but the porta hepatis over here. The longitudinal part and vertical part is attached to ligamentum venosum over here. Okay, and the horizontal part is attached to porta hepatis, and this is the free border of the lesser omentum where you will get the epiploid foramen over here. Got it or not? Right. So this is the lesser omentum, 2 layers. So do you think that this lesser curvature of the stomach is covered by the peritoneum or not? The lesser curvature of the stomach is covered by the peritoneum or not? Why? Why yes, why no? Do you think that lesser curvature of the stomach is covered by the peritoneum or not?
So there will be a gap.
Exactly. Why that gap has happened?
So the layers are going
Exactly. For example, here now we are focusing on the sagittal section of the stomach. Sagittal section of the stomach. Okay. So this is the lesser omentum and this is the greater omentum over here. Okay. So whenever the 2 layers of the lesser omentum are coming over here, they will diverge at the level of the lesser curvature over here. So lesser curvature is not covered by the peritoneum over here. And again these 2 layers will be enveloping the stomach and goes towards the greater curvature over here, and again they will join together. And this area, wherever the greater curvature is present, that is not lined by the peritoneum over here. Getting it out? Right? So towards the lesser curvature, it is not lined by the peritoneum. Towards the greater curvature also, it is not lined by the peritoneum. One more area which is not lined by the peritoneum of the stomach is cardiac end of the stomach. Over here. Exactly. Cardiac end of the stomach. So whenever the stomach is getting enveloped over here in this manner, so it will leave a gap at the cardiac end of the stomach over here. Try to understand this. Okay. This cardiac end of the stomach will leaves a fold over here, fold of peritoneum over here in this manner, leaving a gap over here towards the posterior aspect of the gastric end of the stomach over here. Try to understand this now. Okay. For example, this is the stomach over here. It is enveloped by the greater end. What is it? Lesser omentum over here. Okay. So, but whenever, for example, this is the fundus and this is the body and pylorus, for example, at the level of the cardiac end of the stomach, these 2 layers will be enveloped, but leaving a gap on the posterior aspect of the cardiac end of the stomach over here. Okay, this is the anterior end of the stomach, this is the posterior aspect of the stomach. Towards the posterior aspect, it leaves a gap in this manner. And this fold of peritoneum will be directly attached to the diaphragm over here, towards the left crest of the diaphragm. That fold is termed as gastrophrenic ligament. Are you able to understand or not? The stomach is actually enveloped all the way from lesser curvature, which is starting at the cardiac end of the stomach. Is it not? This is is a lesser curvature of the cardiac, from the cardiac end of the stomach till the pyloric orifice over here. Okay. And this is the greater curvature which is starting all the way from the cardiac end of the stomach and will be enclosing this entire greater curvature till the pyloric orifice of the stomach over here. Okay. But whenever it is enclosing, that means the posterior layer and anterior layer of the peritoneum are enclosing, it will leave a gap on the posterior aspect of the cardiac end of the stomach. Getting it out, right? For example, I am wearing a shirt over here. Towards this part, it is not covered. This part is not covered. For example, imagine that this is the posterior aspect of the cardiac end of the stomach over here. Okay, this part is not covered, and this is straight away will be connected to the diaphragm over here. Getting it out? Forming the gastrophrenic ligament over here. Getting it out? So this area which is not covered by my shirt is nothing but the bare area of the stomach over here. So far we have seen bare area of the liver, and this is a bare area of the stomach over here. Exactly in this column. So actually this is the anterior layer. So this is the posterior layer. This is the anterior layer of the peritoneal folds over here, and this part is not covered by, this is the cardiac end of the stomach, for example, it is not covered. Whenever it is reaching over here, it is not covered by the peritoneum over here, but this part is directly connected to the diaphragm above, forming a fold, triangular fold in this manner. Getting it out? So this fold of peritoneum is termed as gastrophrenic ligament over here. Just like the gastrosplenic ligament, this is the gastrophrenic ligament over here. Understood or not, everybody? Right? This is the gastrophrenic ligament which is connected straight away from stomach, cardiac end of the stomach till the diaphragm over here. Okay. So this is the arteries over here. One is the left gastric artery, which is a branch of left gastric artery is a branch of So what are we discussing here? What are we discussing now? What is it? What's going on over there? Cricket now? Okay. What is going on over there? So what is going on over here? What is going on over here? What we are discussing over here? What? Left gastric artery, which is a branch of? Left gastric artery, which is a branch of? Anybody? The last one? The last two? Celiac trunk. Right gastric artery is a branch of? Right gastric artery is a branch of? Common hepatic artery proper. Common hepatic artery. Right gastric artery is a branch of? Common hepatic artery. What is the difference between common hepatic artery and proper hepatic artery? What is the difference between common hepatic artery and proper hepatic artery? Anybody? What is the difference between common hepatic artery and proper hepatic artery? From when it will be called as proper hepatic artery? What is it? Exactly, after giving a branch called the right gastric artery, it is termed as, the same artery is termed as hepatic artery proper. Why it is called hepatic artery proper? It is supplying only liver and its related structures. Isn't that right? The hepatic artery proper will be divided into right and left hepatic arteries. Among them, one of the artery will be giving rise to cystic artery, right? Cystic artery. Okay, right. Fine. So, okay, this is the left gastric artery branch of celiac trunk, and right gastric artery is a branch of common hepatic artery, not the proper hepatic artery. Okay, so it is common to stomach and other things. Okay, discuss the thing. So these will be anastomosing within the lesser curvature of the stomach. Okay, try to understand this. Lesser curvature of the stomach will be getting blood supply all the way from left gastric artery and right gastric artery. Of course, the adjacent areas, anterior superior surface and posterior inferior surface, also will be supplied by these arteries over here. Okay, and then forward towards the greater curvature, what are the arteries which are anastomosing over here? Right gastroepiploic artery, which is a branch of? Right gastroepiploic artery, which is a branch of? Right gastroepiploic artery is a branch of? Look at me. Guys, what is the branch? Right gastroepiploic artery is a branch of? Got it? Pakka gastroduodenal artery, yeah? Pakka? Okay, left gastroepiploic artery is a branch of. Left gastroepiploic artery is a branch of the last guys. Left gastroepiploic artery is a branch of splenic artery. Okay, fine. So the right gastroepiploic artery is a branch of gastroduodenal artery, and left gastroepiploic artery is a branch of splenic artery. Both will be anastomosing over here, and will be supplying the anterosuperior surface and posterior inferior surface, and of course the greater curvature of the stomach also. But these vessels will be giving rise to these branches over here towards the greater momentum over here. These are called the epiploic branches over here, which supplies the greater momentum over here. Gastric arteries will be supplying the stomach alone over here, and then these gastroepiploic arteries will be supplying, because it is gastroepiploic arteries, not only supplies the stomach but also supplies the greater momentum over here through these arteries, which are called the epiploic arteries over here. Epiploic arteries over here. Okay. So where could you find these epiploic arteries? In between which layers? In between which layers, right? For example, totally 4 layers of greater momentum are present.
Second and third.
Second and third এর মধ্যে তো ফাঁকা।
See here, this is the left gastric artery and right gastric artery within the lesser momentum over here. In this gap, these arteries will anastomose over here, and within this gap, this gastroepiploic arteries will anastomose over here. So in which layers, in between which layers of the greater momentum, these vessels will be found?
First and second.
First and second, and also third and fourth. Is it not? First and second goes downwards and takes a turn backwards, and third and fourth layers. Not between second and third layers. Is it not? Right? The momentum are the peritoneal force which will be carrying the nerves and the blood vessels. Getting it out? The function of the peritoneal force is to either momentum or mesentery or mesocolons. These are the things which are the peritoneal force which will be carrying the blood vessels and nerves towards these viscera or organs over here. Getting it out? So main purpose of the mesentery or mesocolons or omentum are to carry the blood vessels and nerves towards the required viscera over here. Getting it out? So these vessels, epiploic vessels, will be present in between the first and second layers and third and fourth layers, not between second and third layers over here. Getting it out? Try to remember these properties. Okay. So the gastric ulcers are common towards the lesser curvature of the stomach. Why? Less blood flow. Why there is a less blood flow over here? See everybody, how the arterial supply occurs over here and why the gastric ulcers are common towards the lesser curvature of the stomach compared to the greater curvature. It is not like the gastric ulcers doesn't occur towards the greater curvature. There is a chance of occurrence of greater curvature also, but most predominantly occurs towards the lesser curvature of the stomach. What might be the reason? See here, for example, these are the 2 gastric arteries, left gastric artery and right gastric artery. These will be passing in between the 2 layers of the lesser momentum over here. These are outside now. These will be sending branches into the wall of the stomach. First of all, into the which layer over here? What are the layers of the GIT? Okay, from outside inwards it was serosa, muscularis externa, submucosa and mucosa. Okay. So whenever these are outside the wall of the stomach, here will be Serosa, isn't it? Here will be the serosa. Outermost layer of the stomach is the serosa. So here it will form a plexus. Plexus means network of blood vessels over here. There will be a plexus which is formed within the serosa over here, which is called the subserous plexus over here. What is that? Subserous plexus. And from this plexus, some more straight arteries will be going into the which area? Passing through the muscularis externa, enters into the submucosa, and again it will form the submucous plexus over here. Getting it alright? Submucous plexus, and finally enters into mucosa and supplies the entire mucosa. Got it alright, everybody? Right? First of all, the arteries are outside the stomach wall, then passing towards the stomach wall over here. Outside the stomach wall will be the serosa. So there it will form the serous plexus, subserous plexus. Then they will pass through the muscles, nothing but the muscularis externa. How many muscles will be present in case of stomach? 3 muscles. What are those? Outer, longitudinal, middle circular, and inner oblique layer. Okay. 3 layers of muscles which are forming the muscularis externa, and through the muscles the blood vessels will form straight away into the submucous region over here. That will be forming the submucous plexus, subserous plexus and submucous plexus. From here, straight away arteries will be going and supplies the mucosa actually. Getting it alright? So what is happening over here? What is happening in case of lesser curvature? What is happening in the lesser curvature? Submucous plexus are not present over here. In case of lesser curvature of the stomach, the submucous plexus are not present. And veins will be forming all the way from this part over here. Getting it alright? Submucous plexus will not be present in case of lesser curvature of the stomach, but these are present in case of greater curvature of the stomach. Okay, so the venous drainage occurs even before the vessels which are passing through the submucosa over here. Getting it alright? So for example, this part is the submucosa and this part is the mucosa over here. So even before passing through the submucosa, the veins will be draining the blood all the way from the gastric wall over here. So the blood will be entered over here. Very little amount of blood will be passing through these straight vessels, and which are the longer vessels which are forming from the subserous plexus. Submucous plexus is absent, so the lesser curvature stomach is supplied all the way from the subserous plexus over here. So longer vessels will be formed over here, passing through the submucosa and mucosa also. Okay. So, but the venous drainage occurs all the way from at the level of the, or at the junction of the muscularis externa and submucosa over here. So the arterial blood will be passing over here and through the capillaries enters into the veins over here. So majority of the blood is escaped over here before reaching the lesser curvature of the stomach over here. So lesser blood is reaching over here, so it is more prone for ischemia over here. That ischemia leads to the formation of ulcer over here, following the gastric acid action over here. Getting it over? So here the blood supply is less compared to the greater curvature over here because of this reason. And if there undergoes any ischemia over here, that will be followed by the gastric acids invasion over here. That leads to the formation of the gastric ulcer over here. Getting it over? So what are 2 reasons? One is the lesser blood flowing towards the lesser curvature, and one is followed by, what is that? The other one is whenever it is undergoing ischemia, the acid will invade it and leads into the gastric ulcer formation further by means of it leads to perforation of the stomach over here. Getting it out? So this is the reason which will be asked in the examination. Getting it out? Right? So because of the less blood supply, the lesser curvature is more prone for gastric ulcer formation over here rather than the greater curvature. Greater curvature will be having all the plexus, subserous plexus and submucous plexus also. So there will not be any escape of the blood at the submucous level over here. Getting it or not, everybody, right? So this is the reason you are supposed to write over here. Got it or not, right? So this is the blood supply and venous drainage by means of left gastric vein and right gastric vein. So the veins will be draining into left gastric vein and right gastric vein, ultimately drains into the left gastric vein and right gastric vein will be ultimately draining into portal vein over here. Could you understand? The left gastric vein and the right gastric vein, after collecting the blood from the stomach, will be draining into the portal vein over here. Okay, and this vein, what is this vein and what is this vein? This is the right gastrocephalemic vein which will be draining into superior mesenteric vein, because it is very much lying close to the superior mesenteric vein over here. Okay, and the left gastrocephalemic vein will be draining into splenic vein. This you are supposed to remember. What is it? The right gastric vein and the left gastric vein will be draining into the portal vein, and from the portal vein to draining into the liver over here. And then what is this? Left gastrocephalemic vein will be draining into the splenic vein, and right gastrocephalemic vein will be draining into superior mesenteric vein, because it is very much close to the superior mesenteric vein over here. Getting it or not? And the fundus is supplied by, fundus of the stomach is supplied by short gastric arteries, which are the branches of, splenic artery, and left gastrocephalemic artery is also branch of splenic artery. One more branch from the splenic artery is nothing but, what is that mean? Posterior gastric artery, which is the one more branch all the way from the splenic artery over here, from the splenic artery, that will be supplying the fundus of the stomach. So far we have seen the greater curvature and lesser curvature, and anterior superior surface and anterior inferior surface supplied by these four arteries over here, and the fundus of the stomach is supplied by a branch called the posterior gastric artery all the way from the splenic artery, which supplies the fundus of the stomach over here. So how many arteries are the branches of the splenic artery? One is the posterior gastric artery and short gastric arteries, and then one more left gastrocephalemic arteries. Okay, this is very much important. Okay, and why splenic artery is tortuous? Why splenic artery is tortuous? What's that?
Behind the stomach is
Absolutely. If the stomach is expanding, the splenic artery will be stretched. So if it is tortuous, there will not be any tear of the vessel over here. And one more, during respiration, the spleen will be moving, and also the liver also will be moving over here. So during that moment, there is a chance of tear of the blood vessel. So that will be prevented again by means of this tortuosity of the splenic artery. Got it, everybody? Right? So what are the ligaments of the stomach over here? So far we have seen this is the gastrophrenic ligament and lesser omentum and greater omentum. What are the other ligaments? Gastrosplenic ligament. Could you able to remember gastrosplenic ligament or not? Right? So where it is situated? So how it is enveloped, this is very much important. How it is enveloped by means of this so here let us see that the fold of peritoneum in between the fundus and the spleen, this ligament is called gastrosplenic ligament, and the fold of peritoneum between the spleen and the kidney over here, that is called lienorenal ligament. Okay. So you are supposed to understand which layers belongs to greater sac and which layers belongs to lesser sac. If you see properly, this is the part of the greater omentum. Okay, greater omentum, which is going towards the hilum of the spleen, and then turns back and encloses the rest of the surface of the spleen, medial surface or visceral surface of the spleen, and encloses the diaphragmatic surface of the spleen on this side over here, and goes back and again goes towards the hilum and will be returned back at the level of the kidney over here. Kidney will be situated over here. Getting it out, right? So these layers, whatever you are saying, for example, the layer which is covering the spleen, okay, this layer belongs to which sac over here? This layer, whatever this layer is covering the spleen, is belonging to greater sac, and this layer which is belonging over here to greater sac again. But this layer, for example, this is a gastrosplenic ligament over here. This is the posterior layer, this is the anterior layer over here, is it not? So this is towards the posterior aspect and this is towards the anterior aspect, is it not? This is directed in this manner, this is directed in this manner, right? So this anterior layer belongs to greater sac over here, and this posterior layer belongs to lesser sac over here. Similarly, with this layer, this is the lienorenal ligament over here. So the anterior layer belongs to lesser sac and posterior layer belongs to greater sac, because greater sac is in between these two folds over here. What it or not, everybody? Right. So these are the various ligaments around the stomach over here. So far we have seen omentum, two omentum, lesser omentum and greater omentum, and then followed with the gastrophrenic ligament over here and gastrosplenic ligament over here. Through this ligament only, the splenic artery will be giving rise to the blood vessels which are supplying the stomach over here. What are the branches? Short gastric artery, gastroepiploic artery, and then what more? Posterior gastric artery over here. So all the branches will be entering all the way from here towards the stomach in this manner. Getting it out? So the gastrosplenic ligament, the contents are nothing but the vessels, nothing but the short gastric arteries, left gastroepiploic and posterior gastric artery over here. Okay, these are very much important. You're supposed to know. Okay. What is the nerve supply of the stomach? Nerve supply of the stomach by means of nerve supply of the stomach by means of two nerves. What are those nerves, right? First of all, the stomach. Try to understand this properly. Stomach is supplied by sympathetic and parasympathetic. Okay. Sympathetic by means of okay. T6 to T9 or T10. It varies, depends on the textures. Okay. T6 to T9 segments of the spinal cord. Okay. And then parasympathetic by means of vagus nerve, right? Vagus nerve, which is nothing but the left and right vagus nerves. Okay. Sympathetic system will be carrying which sensation of the stomach? Pain sensation of the stomach. So it is not only an activity, motor activity to the stomach over here, but also it will receive pain sensation over here. So what is the motor activity given by this sympathetic trunk over here? So for example, sympathetic nerves will be arising all the way from the which horns, right? Which horns? Lateral horn. Sympathetic nervous system will be arising from the lateral horn of the thoracic spinal cord. Getting it over? So this lateral horns will be joining with the greater splanchnic nerves and will be forming the celiac plexus within the stomach, around the celiac trunk over here. Could you able to remember or not? Could you able to remember or not? Have you studied or not? Spinal cord, the thoracic segments, T6 to T9 segments. Is it or not? T6 to T9 segments. Heart will be supplied by means of T1 to T5 or T4 segments over here. Okay. The stomach will be getting the sympathetic nervous system from T6 to T9 segments of the spinal cord. It's not related to the vertebra. Try to understand this properly. Okay. Spinal cord contains cervical segments, thoracic segments, lumbar segments, and sacral segments over here. Okay. Among them, the thoracic segments, which are from T6 to T9 segments. If you divide the entire spinal cord into multiple small segments over here, each and every bit is nothing but a segment of the spinal cord. There you know. So, for example, these are the thoracic segments over here, from T6 to T9 segments over here. Okay, of the spinal cord. Okay, these will be entering into the abdomen through the greater splanchnic nerves. We have read already, greater and lesser and least splanchnic nerves. The greater splanchnic nerves will be entering into the abdomen, and that will be forming the celiac plexus, and then further followed by the superior mesenteric plexus over here. Okay. So the celiac plexus means the plexus of nerves around the celiac artery or celiac trunk over here. Okay. This celiac plexus will be giving rise to the nerve supply for the stomach over here. So from the sympathetic spinal cord segments over here, through the celiac plexus of the nerves around the celiac trunk over here, the sympathetic nerves will be reaching the stomach over here. Getting it down? All the way from spinal cord through the celiac plexus and enters into the stomach over here. So that is the sympathetic nervous system supply for the stomach over here. Which segments of the spinal cord? T6 to T9 segments of the spinal cord. So these will not only supply the motor activity for the stomach, but also carries back the pain sensation. Remember this properly, the pain sensation of the stomach is carried by means of sympathetic nerves. But the hunger and nausea means vomiting sensation will be carried by means of parasympathetic nervous system. Three sorts of sensation. One is pain, which is carried by the sympathetic nervous system. One is nausea or vomiting sensation, and hunger will be carried by the parasympathetic. Three sorts of sensations, two different nervous systems over here. Try to remember this problem. Okay. So whenever there is a pain because of the gastric ulcer or whatever it might be, so this pain will be carried to which area of the dermatome? Which area of the abdomen? Dermatomal region. What are the dermatomes we have seen so far in the abdomen? For example, stomach is a deeper structure. Is it or not? Compared to the anterior abdominal wall, stomach is a bit situated deeper. Right or not? So whenever you get the pain in the stomach because of the gastric ulcer or whatever it might be, so that will be carried all the way from through the sympathetic nerves into the spinal cord segments. But that will be carried or referred again back to the abdominal dermatomes over here. What is the dermatome? An area of the skin supplied by a particular spinal cord segment over here, right? So the pain is carried over here, and that will be referred again towards the surface of the abdomen over here, anterior abdominal. So where it will be referred over here? Starting from the epigastrium, just above the umbilicus. All the way from epigastrium, just above the umbilicus. So this entire area is getting referred pain through this dermatomal region over here, or through this dermatome, whenever there is a pain in the stomach over here. Getting it or not? So you are getting not only the pain deeper in the abdomen, but also you will be getting pain superficial to the abdomen, also over the skin. Getting it or not? At the same time, if you have a cardiac ischemia or infarction, you will be getting pain in the epigastric region. Why so? Last exam question. Exactly. So some fibers will be reaching the T5 and T6 segments also. Getting it on? The dermatomes which are reaching the epigastric region will also be carried back to the T5 and T6 segments, which will be supplying the heart over here. Heart not only carrying the pain sensation towards the T1 to T4, but it will be carried towards the T5 and T6 segments also. Getting it on? So whenever you get an ischemia over here in the heart, that will be referred towards the epigastric region because of this reason. Got it or not, everybody? Right? So the pain will be carried through the sympathetic system, but will be referred towards the dermatome through this dermatomal nerves over here. Got it or not, everybody? Right? So if a patient is complaining of pain in the epigastric region, superficially, so where might be the pathology over here? Either heart or stomach. Getting it or not? What is the nerve supply of the stomach, right? Sympathetic and parasympathetic. What sympathetic nervous system does to the stomach over here? Sympathetic nervous system. Sympathetic gastric emptying. Inhibits gastric emptying. So the gastric musculature within the wall of the stomach will be inhibited. That means the stomach will undergo relaxation over here. Getting it? And what it does to the sphincter? It will be contracting the sphincter over here. So the stomach is relaxed over here. You can eat the food, and the food will be reserved over here. Getting it? But it will not be escaping into the duodenum. Okay. So first of all, storage of the food and will not be escaped into the duodenum. This is the function of the sympathetic nervous system. What does the parasympathetic system does? The parasympathetic does exactly opposite to it. It will be contracting the gastric wall muscles over here. So the churning and mixing of the food occurs over here. And later on, it must be after churning, the food must be passed out into the duodenum over here. So what the sphincter must be undergoing over here? Relaxation over here. So the parasympathetic system is contracting the gastric musculature over here and relaxing the sphincter over here, so that food will enter over here. So when does these things happen over here? For example, initially for the sympathetic activity, it is closed over here and it is open over here. We are taking the food, right? But here, whenever the parasympathetic activity is activating, this is relaxed and this is contracting over here. So when does the sympathetic and parasympathetic nervous systems will act? One after the other or simultaneously? Empty stomach? Okay. So whenever you eat the bolus, Okay, whenever you eat a small bolus of the food, do you think that stomach will be kept silent till you fill the entire stomach? No, it will be start contracting. But still you will be eating and it will be contracting. So whenever it is contracting, the sphincter must be relaxed. So what is happening over here? So whenever it is contracting, it will be easily escaping into the duodenum over here. So the sympathetic and parasympathetic nervous systems act simultaneously, but one will be dominating over the other based on the action over here. Getting it, whenever it is getting stored, it will be by means of sympathetic activity, but for the churning purpose, parasympathetic activity will occur over here. Getting it? But whenever the food must be delivered into the duodenum, the sphincter will be relaxed by means of parasympathetic activity. But whenever the churning is going on over here, this will be closed by means of sympathetic activity. Both will be simultaneously acting over here, but based on the function, it will be acting with a dominant action over here. Got it, everybody? Right? So the vagus nerves will be coming over here and will be supplying the stomach. So what are the two vagus nerves? Right and left vagus nerves. Right nerve will be becoming posterior and left nerve will be becoming anterior. Both vagus nerves will be having a bigger nerve, that is nothing but nerve of Latarjet. Okay, Latarjet. Nerve of Latarjet is the biggest branch of both the vagal nerves over here. Okay. For example, this is the right vagus nerve. It will be divided into which nerves? Hepatic branch and gastric branches over here. This hepatic branch again divides into ascending and descending branches. Ascending branch will be supplying the liver which will be supplied over here. What it is supplying the liver? Porta hepatis, but not absolutely porta hepatis. What structures exactly? What is it? Gallbladder. To make the gallbladder to empty, this must be acting over there. Getting it over, right? And the descending branch will be supplying the stomach, but at the level of the pyloric region over there. The pyloric region will be supplied by means of this descending branch of the right vagus nerve. Getting it over? And the left vagus nerve will be giving rise to nerve of Latarjet over here. That will be divided into celiac branch and gastric branch over here. Try to remember. Right gastric nerve, right vagus nerve will be divided into hepatic branch, because the right side liver is present, hepatic branch and gastric branch over here. This gastric branch will be supplying the pyloric part of the stomach, and this ascending branch will be supplying the liver, or indirectly gallbladder, we can say that. Okay. And left vagus nerve will be supplying the stomach by means of gastric branch, but one will be forming the celiac branch over here. That will be joining with the celiac plexus over here, through which it will be supplying the intestine till the junction between the right 2/3 and left 1/3 of the transverse colon. Okay. So through this celiac plexus it will be supplying the intestine over here. Getting it out? But this gastric branch will be supplying the stomach. Getting it out? Right? One nerve from the left vagus nerve will be going towards the fundus, that is called nerve of Grassi. Okay. So nerve of Grassi will be supplying the fundus of the stomach over here. Try to remember this. So right vagus nerve, gastric branch and hepatic branch over here. Hepatic branch will be supplying the liver and pyloric part of the stomach, and gastric part will be supplying the stomach over here. Hepatic part and gastric part. And left vagus nerve will be supplying the gastric part over here, and celiac branch over here, which will be supplying the intestine till the junction over here. Getting it over? These are the two vagus nerves. And this is the nerve of Grassi, which is a branch from the left vagus nerve, which supplies the fundus of the stomach. Got it already? All these gastric branches will be supplying the fundus, body, and of course, pylorus will be supplied by this nerve over here. Got it already? These are the theoretical things you can study. Just I'm mentioning this. Okay. So whenever the patient is more prone for gastric ulcer, there are three tomes will be coming. What are those? Selective selective vagotomy and highly selective vagotomy. Okay. Selective vagotomy means whenever you cut the bigger nerve, nothing but the nerve of Latagen. What is the use of cutting these nerves over here? Exactly. The parasympathetic activity, what it does, it will be helping in secretion of the glands. Getting it over? Anywhere in the body, the glandular secretions occurs by means of hormonal activity or nervous activity. The nervous activity of the glandular secretion occurs by means of parasympathetic nervous system, nothing but the vagus nerve. So in case of parietal cells which will be secreting the hydrochloric acid, so this vagus nerve will be stimulating the parietal cells over here. So whenever you cut this nerve of Latagen which is supplying the parietal cells over here, so the parietal cells will not secreting the HCl over here. So the gastric ulcer will be prevented over here, further prevented. Getting it over? So whenever you cut the nerve of Latagen, it is called the selective vagotomy. But whenever you cut these small branches over here, those are called the highly selective vagotomy. Getting it over? Highly selective vagotomy. But you can cut the trunks also over here. So what will happen if you cut the vagal trunks over here? No more gastric motility over here. Getting it over? The gastric motility will be absent. So what will happen? The patient must be done gastrojejunostomy, bypassing the pyloric part of the stomach and duodenum also. Getting it over? So the food straight away enters into the stomach and will be carried towards the jejunum over here. Getting it over? Gastrojejunostomy will be done in case of removal of the or cutting the trunks over here. Getting it over? So highly selective vagotomy and truncal vagotomy over here. Okay, trunks we are cutting over here. Whenever we cut both the trunks over here, the stomach will become atonic. Atonic means there will not be any contractions occurs over here. So because of that, the gastric emptying is prevented because there is no churning and opening of the sphincter over here. For that sake, the food must be passing all the way from stomach towards the jejunum by bypassing this over here. That is nothing but the gastrojejunostomy. What?
Why is the duodenum also bypassed?
Because it can't be entering over here, but if the acidic thing over here enters into the duodenum, that will lead to peptic ulcer. It is stored over here. Okay. So whenever it will be carrying the acid over here, that acid will not be carried towards the duodenum. So if it gets straight away the acid thing over here, that will lead to peptic ulcer over here.
So the acid content can come to the jejunum?
Yeah, let it come down. See, all the way from duodenum onwards, there will be alkaline, what is it? Bicarbonate secretion will be there. So it will be neutralized over there. Getting it? From the duodenum onwards, bicarbonate ions will be secreted. So the stomach contents will be neutralized over here. So obviously that's the thing over here. Got it? So gastrojejunostomy done. So to prevent because the contraction of the stomach is prevented over here. So the gastrojejunostomy is done. So few complications will be there. That's pakka. Okay. So the patient will be having diarrhea and all over thing over here because of this vagotomy, truncal vagotomy over here. Getting it out? So few complications will be there, but the patient must be survived because of this passage of the stomach contents directly into the jejunum over here, jejunostomy. Gastrojejunostomy. Straight away the stomach will be anastomosed with the jejunum over here, bypassing the duodenum and everything. Getting it out? Right? So this is the use of truncotomy. Most probably it will not be done. The highly selective vagotomy is the most preferred things over here. So let us see the visual.